Okay, so the next thing we have to, that is very important for NCLEX part of you, fetal monitoring, because this happened during the first stage of the labor. You have to monitor the fetal heart rate. So it happens by two ways. You will put either external fetal monitoring or internal. So external is like you will put external non-invasive transducer on the mother's, like, or a Doppler ultrasonic transducer on the mother's, like, abdomen. You will find the fetal bag and located. Where is it? Usually it's there. Like from the fetal bag, you can find the place where you're gonna place over the transducer, because it should be close to the fetus heart, right? And then you will place transducer. Transducer will help you to find the fetal heart rate. And then a client should be allowed to lie down in a comfortable position. Usually it's the left position. And so internally is like when you place the fetal monitoring device through the invasive, like rupturing of the membrane. So we did studied that in case of HIV, like HIV and hepatitis B, those cases we don't like do PV examinations, right? Because to prevent the exchange of the blood with the mother and fetus. So in this case we're gonna avoid doing the internal fetal monitoring unless it's very urgent, right? Okay, so the normal fetal heart rate is 110 to 160 beats per minute. Anything less than 110 is scary, and you should be worried about it. So first fetal pattern in heart rate is like bradycardia. If the fetal heart rate is going less than 110 per minute for 10 minutes or longer, it means you will say that fetus heart rate, the heart rate है जो cut दिया, right? Tachycardia will be considered when fetal heart rate is going more than 160 beats per minute for more than 10 minutes or longer. Okay, so if the fetal is in bradycardia or tachycardia stage, what will you do first, right? So you can remember it from line. Line is like a like easy to remember thing. First you will do change the position of the mother, like lie down in left side or left side position, then administer the oxygen, then check the mother's vital. These are the first thing you will do. Like if mother is laying on her back, you should put her in the like left side position, then put oxygen either by nasal cannula or up to with mask up to 6 liter, or then do the vital signs, then notify the doctor, right? Okay, so what are the bad things that you will have to notice? First is variability. जेकर fetus the heart rate है ਜਿਹੜੀ बहुत ज़्यादा fluctuate ਹੁੰਦੀ है, then that is like concerning. It could be either absent or undetected. That is like fetus is not doing too well, right? So if fetal heart rate is low, less than 10, so we're gonna take the mother to the left side, give IV fluids and oxygen and notify the doctor, right? Take the vitals. Okay, if low baseline variability, when fetal heart rate stays the same, does not change, that's a concerning thing too. You have to turn the mother on the left side, notify the doctor, administer the oxygen and do the IV things, right? So if acceleration, if you see the fetal heart rate temporarily increase 15 beats per minute and it lasts for 15 seconds, this is a good sign. You don't have to do anything. So if you see in the screen acceleration, that means high fetal heart rate. It is going to increase from 160 like 15 beats per minute more than like the normal baseline. If the fetus baseline heart rate is 120, so every time there is a moment in the fetus, the heart rate is increasing by 50 beats per minute, and it's lasting for 15 seconds, then it's a good sign. You don't have to do anything. This is okay, right? If there is a early deceleration, deceleration means decrease. So you can from the word you can say it's decreasing, right? So if there is early deceleration, which means the heart rate is decreasing, from the baseline, right, and remaining up to 100 beats per minute. And then it means it is happening due to the head compression, that the baby's head is compressing against the pelvis or the cervix or the soft tissues, right? So in this condition, what you will do, it doesn't need any specific like interventions. It will, as soon as the baby move, contraction stops, the thing will come back to the normal, and then it's fine. But if it's going more than less than 100 beats per minute, and then you have to notify the doctor. So early deceleration is happening because of the head compression, but it is fine until the heart rate is staying up to 100 beats per minute, and as soon as the contraction stops, it should be okay, right? And you should just do the documentation in this case. Then late deceleration, this is happening due to the placental insufficiency, and when there is contraction, placenta is not receiving enough blood and causing heart rate is going too low, less than like 100. Sometimes it's go to 90, 95. So in this case, you need to do immediate interventions to like restore the blood flow to the fetus, and right. So in this case, first thing is very important, that if there is mother is on oxytocin infusion, you have to stop the infusion right away first. Then change the position to the left side, apply the oxygen, then IV fluids, and tell the doctor right away they have to do the delivery, right? Because the fetal heart rate is compromising because of the placental insufficiency. So late deceletions are concerning. You have to do something with this one. Okay, then variable deceleration. This is happening because of the umbilical cord compression, and usually in this you don't see any specific pattern like early deceleration, like the heartbeat changes, but it happens because of the cord compression, right? So deceleration will be there, not like, but it's unrelated to contraction. It can happen at any time, and in this condition, you will stop infusion of the oxytocin again, and same thing, you will change the position of the mother and give the oxygen and notify the doctor. So what they do in this case, they will do intrauterine instillation of warm saline to decrease the compression on the cord. It's called amino infusion. So in the amniotic cavity, they will start infusing like a warm saline, normal saline, but in a warm form, and this will have to decrease the compression on the umbilical cord until we deliver the baby. So it's like a temporary measure we do. So these are the three things you have to worry about. So if it's variable, it is happening because of cord compression, you have to do something about it. If early deceleration, it's happening because of the head compression, but it's fine. But if it's acceleration, this is good, you don't have to do anything, and document, take the mother's temperature in case to find out if it's happening because of the fever. Then if it's late deceleration, it's happening because of the placental insufficiency, you have to do something in this one. It is concerning. So you have to stop the oxytocin, change the position of the mother, give oxygen, IV fluids, and notify the doctor. So these are the things you will do in stage 1. And then stage 2. Stage 2 is the stage where like the labor, the process of the delivery happens. So also in stage 1, they have described like how the stage 1 is divided into 2 parts: latent phase, active phase, and transition phase, right? So in stage 1, what happens? It's a long stage 1, that is part 1, latent phase. It's longest part, and it takes time because the dilation part is very slow, 1 to 4 centimeters. and the uterine contraction is 15 to 30 minutes every, and it lasts for 15 to 30 seconds. So in this case you can do like comfort measures, reintegration, ambulation, offer fluids, IV chips, and help in voiding. Then the stage 1, second part, active phase. The dilation will go to now 4 to 7 centimeter, and the contractions will comes more often. That will be 3 to 5 minutes, and it should be more lasting more than 30 to 60 seconds. And same thing in this, one thing we do different is like back rubs, massage, pillow support, those things, because pain is increasing. And then the last phase is transition phase. In this, dilation goes 8 to 10 centimeter, and the contraction comes every 2 to 3 minutes and lasts for 45 to 90 seconds. So in this like you have to very exhausting stage, and you have to keep mother waking up and help her in normal breathing, deep breaths, and ice strips, and help mother push the baby right in the next stage. Next we have interventions for stage 2. So stage 2 usually you like the delivery of the baby happen. So in this, cervical dilation is complete, and the labor will be true labors, and it will be progressing, and the membranes will be ruptured by then, and you will see the fluid coming, and they will be pushing effort by the mother in this case. And so first happens the delivery of the head. Then when the delivery of the head happens, as a nurse, your part should be to suction the mouth and then the nose. So this question comes on NCLEX, what you have to do. In case you have to suction, you suction the mouth first, then the nose. Then next comes the delivery of the neck, and in this you will check the presence of the umbilical cord around the neck. If it's present, then we have to slip it like out of the neck. We cannot deliver it around the neck, right? So you have to look for umbilical cord. Then delivery of the shoulder and the body happens, and immediately you will clean the baby, and you have to be careful if the baby is like the mother is HIV positive or hepatitis B positive, because the care of the baby will be different in that case. And you have to immediately put a tag on the baby, and footprints will be taken and before the baby leaves the delivery area, right? And in this type there will be a doctor present in the delivery room who will check the UPCAR score for the baby, and after checking those scores the baby will leave like in next 30 something 1 hour, right, depend on the condition. Okay, next we have stage 3, which is delivery of the placenta. So we have a placenta separation occurs in this one after 5 to 30 minutes of the delivery of the baby. So there are two ways of delivering placenta. First is the Sattrell's mechanism. In this, the central portion of the placenta separate first, and its shiny fetal surface emerge from the vagina, right? Second is Duncan mechanism. In this, the margin of the placenta separate first, right? In this, red dull blood that comes out. So usually there is if there is how you will see the placenta is separating, you will see the height of the uterus is decreasing, and cord will be coming out, and you will see gush of blood coming out. And when there is delivery of placenta, you have to make sure it's intact, and it has 3 vessels, 2 arteries and 1 vein. If something is missing, you have to make sure you will evacuate the whole uterus, so there will be nothing remaining inside, right? After expulsion of the placenta, uterine fundus remain firm and 2 fingers beneath the umbilicus, and it should be, if it's rigid, you have to massage the uterus and help the mother to keep warm, right? Sometimes they also give misoprostol tablets to help in the delivery of the placenta if it's slow. Then last stage is fourth stage, that is recovery stage. So in recovery stage, it's very important stage. What you do, four things you do 4 times per hour in the fourth stage. So in 1 hour you will do these 4 things 4 times. Vital signs check, you have to check for the signs of the shock. If blood pressure is going down, heart rate is going up, mother looks cold, clammy and pale, it's a concerning sign, it's a signs of the shock. You have to inform the MD. And then you have to check the fundus. If it's bogey, then you have to massage it. Like if it's soft bogey, you have to massage it. If it displays, if you look like it should be in the center. If it's to the left or right, it means the bladder is in the way. You have to is too full and mother is not able to pee, so you have to put a catheter. So first thing is vitals. Next fundus, it should be rigid. Like if it's too soft bogey, then you have to massage it, right? Then next is check the pads. If bleeding is too much, if mother is saturating one pad in 15 minutes or less, it's a case of postpartum hemorrhage. You have to inform the doctor. When you're checking the mother for bleeding, you also have to turn her to the side to check the bleeding at the back, right? Sometimes the bleeding goes at the back and you see like that patient is not bleeding more than normal, so it goes missing. So you have to roll her over and check the bleeding underneath her. So these are the 4 things you will do: vital signs, fundus, pads, and rollover. And postpartum assessments will include you have to uh, assess the breast for any engorgement, any infection signs, if it's too firm, right? Then uterus, same, you have to, it needs to be firm. If it's boggy, you have to massage it. It should be in the midline. If it's not, either left or right, you should put a catheter. And then check the fundal height every day. It's height to the fundus later to the belly button. Fundal height is equal to the day of the postpartum, right? Yeah, so up to belly button every day should be decreasing. On fourth day it should be like below 4 centimeter below on the fourth day, right? Then bladder, for the urination, bowel, lochia, those are the secretion that comes after the delivery. Is divided into 3 different colors: rubra, serosa, and alba. Rubra is first, then serosa is second, that is pink, then alba is third. Usually it happens till 15 days. Then if you did the incision for the delivery, then you have to assess that area for the infection. Hemoglobin will tell you if mother is going into shock, and also the mother's extremity, especially the lower legs, for the signs of DBT. And if the calf muscle pain is there and it's tender and warm to touch. Affect is the mother's behavior towards the baby and any discomfort. So if you see this is the bubble head, you have to remember this bubble head thing, and from this you can remember what you will do in postpartum care for the mother. So that's all about the labor.